I would like to give the floor to Jean-Luc, CEO of the World Health Federation, to touch on the overall proceeding and the rich exchange ahead. But let me retire that I delight and privileged to participate in this World Health Summit, to forge a path together that will help make hearts healthier and reduce premature mortality from cardiovascular disease. Thank you, really, thank you very much.
Thank you, Daniel. Dear friends and distinguished guests, I echo Daniel's warm welcome to the 8th World Heart Summit 2023, and our delight in hosting you for a thought-provoking program with invaluable opportunities for learning, questioning, and sharing. We're mindful that heart disease remains the leading cause of death globally, and this is unlikely to change unless we come together optimistic that we can find the solutions and act with the urgency that is needed. Through a series of panel discussions, fireside chats, we will focus on the critical policy, scientific, and technical aspect of heart health and underpin access to prevention and care. But we must also address the non-medical and more personal side of health as we think about how to engage and be led by the communities most affected by heart health. We will hear from renowned experts representing health, science, civil society, government, and business. They are practitioners, researchers, investors, policy setters, and patient advocates. From health system financing to diagnostic, and from digital health intervention to communicating and advocating for cardiovascular health, the summit is a stimulating space where we join forces toward the shared goal of cardiovascular health for everyone. Our calls to action will reach behind the field of cardiology or cardiovascular health to inspire other sectors such as policy and finance to mobilize towards this goal. Let us use this summit as a platform for renewed commitment and action that save countless lives and improve life. On behalf of the World Heart Federation, I express deep gratitude to our partners and sponsors who have made this 8th World Summit possible. Roche, Amgen, AstraZeneca, Bristol Myers Squibb, CSL Vifor, the Mended Hearts, MSD, Novartis, Novo Nordisk, Amarin, Biotricity, CardioSignal, Lawsolds, and Siemens Healthineers. As we extend our special thanks to République and Canton de Genève, the Geneva Convention Bureau, and Biotech Campus for their critical support. It is now my great pleasure to introduce a video message from Dr. Tedros Adhanom Ghebreyesus, Director General of the World Health Organization, leading advocate for cardiovascular health.
President Daniel Piñeiro and Mr. Jean-Luc Eiselé, Excellencies, dear colleagues and friends, heart disease is the world's biggest killer, claiming 18 million lives every year and affecting over 500 million people. People with cardiovascular disease are among those most at risk of severe disease and death from COVID-19. WHO is committed to supporting all countries to prevent heart disease by addressing its risk factors and to expand access to quality treatment for all who need it. Through our Hearts Technical Package and recently launched hypertension guidelines, the Global Diabetes Compact and the Replace Initiative to eliminate trans fat from the global food supply, we are giving countries the tools they need to implement policies that save lives. And by supporting countries to promote physical activity and fight tobacco and air pollution, we're working to keep hearts healthier. WHO is proud to partner with the World Heart Federation to improve cardiovascular health for everyone, everywhere. Ministers of health, policy makers, civil society, academia, the private sector, and health workers, all of you have a role to play. Thank you all for your commitment to promoting and protecting healthier hearts around the world. I wish you a productive and successful World Health Summit. Thank you.
Thank you, Dr. Tedros. It is now my pleasure to introduce Bojana Pervan, Director of Strategy and Communications at WHF. We will alternate as masters of ceremony and guide you through the program. Bojana, over to you.
Thank you, Jean-Luc. Ladies and gentlemen, it is my great pleasure and honor to be with you over the next 2 days and to embark on a journey of discovering of new ideas, establishing trends, meeting old friends, making new ones, and hopefully, possibly, have some fun along the way. Speaking about fun, let me tell you that this year we have a World Heart Summit app, and I encourage you, if you haven't done so already, to download the app as I'm speaking. You will see that the app features interactive, you can connect with people, you can network, and most importantly, you can also put your knowledge on cardiovascular health to the test. We have developed a quiz, and we will be showing from time to time on the screen the results of that quiz, of the poll, and we'll be displaying the names of those who got it wrong. I'm just joking. As you're downloading the app, let me introduce the first session. It was already somehow introduced and set the stage by our president, Daniel Piñeiro. It will be about the World Heart Vision 2030, which we launched last year, and which sets the stage for the next, now what, 7 years, achieving cardiovascular health for everyone. Our next session will just see, looking back and looking forward, what does progress look like? Where are we in bridging the gap between scientific knowledge and implementation? Where are we including CVD in the climate agenda and health policies, leveraging innovation and technology? And absolutely most importantly for our mission, where are we on improving health equity? You see, equity is one of the values of the World Heart Federation. It is my pleasure to introduce Arianne Alcorta to the stage. She will moderate the first half of this year's opening plenary. Arianne is a journalist with over 10 years experience in the industry. She has worked for some of the most prestigious news organizations in the world, covering a wide range of topics, including politics, business, social issues, and now heart health. Arianne, over to you.
Wow, thanks, Bojana. That was a really great introduction. We all know that cardiovascular disease is the biggest killer worldwide, at least here inside this Congress. But outside, nobody talks about it. We all remember how we acted when COVID-19 was declared a global health pandemic. We are increasingly hearing about the actions taken to fight climate change. But cardiovascular diseases, we don't see any candidate running for presidency mentioning this. We don't hear it or read it in the media, and hence, people are not really worried about it. So why to this day are cardiovascular diseases still being overlooked? How can we be more aggressive at placing cardiovascular diseases at the top of political, health, and climate agendas? How can we innovate at adopting technologies and new guidelines equitably across the globe? Today, we will be answering these and many more questions at this World Heart Vision 2030. As Bojana was mentioning, my name is Arianne Alcorta, journalist and international event moderator. It will be my pleasure to be guiding you through this session. So without further ado, please allow me to introduce our distinguished and very diverse panel of speakers. Let's start off with Ivor Benjamin, former president at the American Heart Association. Junbo Ji, president of the Chinese Cardiovascular Association. Dipti Itchhaporia, President of the American College of Cardiology, and Monika Arora, President of the NCD Alliance. Please do take a seat. Now, Ivor, I want to start with you, and I want to start by setting the stage here by telling everybody here the main reasons why cardiovascular diseases are still not at the top of our priorities.
Well, first of all, wonderful question, but I'll be remiss if I did not also say how pleased I am to be part of this distinguished panel. I would say that as a preeminent journalist, you know more than anyone else what drives the news cycle. And so unless it's a famous politician who is running and may have died from a heart attack, you see, we just don't talk about it. But we know that cardiovascular disease and stroke are being impactful in the lives of everyday people, be it a mother, a father, a grandparent who's caring for a loved one, and they don't probably have that chance to be able to talk about the driving risk factors around hypertension, diabetes, smoking. And so I think it's an opportunity for us to really also think about our own successes. We know that there are life-saving drugs, we know about interventions, we know about, obviously, chain of survival. But at the American Heart Association, we are fundamentally committed to discovering the science so that we may better be able to have a world free of heart disease and stroke.
All right, so to summarize in just a few words, give me 3 main reasons why we don't talk about the dangers of cardiovascular diseases.
We need to continue to engage with our partners across the stage, be it in the media, be it in our communities, be it in our homes, in our lives. Actually beginning, obviously, with prevention, even in our schools. Okay,
but 3 reasons, just the reasons why we don't talk about it, just to lay them out there. I don't know if any of the panelists here can have any ideas to, is it because, I don't know, cardiologists need to advocate more or need to communicate better with patients, or because, I don't know, we should be more aggressive at taking at the political level?
Well, I think it's, you know, I mean, if I can be so bold, what grabs attention? You know, there is a flooding, there is obviously natural disaster, the cameras are rolling, we're distracted by the news media and everything else. So those tend to be sort of media grabbing attentions. So
why do we talk more about malaria and HIV and not about cardiovascular disease, for example?
Well, let me just be honest, we need to do a better job. How's that? And I think that this panel was helping, if you will, to put a fire under our seat. We need to do a better job.
Well, I mean, quite frankly, cardiovascular disease is complex, right? There are multiple risk factors. We're not just talking about, although it's cardiovascular disease, we're not talking about one entity. It's complex. So I think that we just have to continue to do a better job at communicating not only the risk factors, and when we think we've communicated, we need to communicate some more. It's something that we can't take our eye off the ball, so to speak.
Communication, extremely important. And we will be discussing more about that in the next panels as well. And that's, well, precisely why we're here, right? It's all about dialogue. Now, let's remember that Vision 2030 is around the corner. In less than 7 years, we should be seeing many of the hurdles we see today resolved. And that includes the inequity in medical care. Today, there is an 18-year gap in life expectancy between the poorest and richest countries. Okay, and that is in big part because approximately half of the world's population is unable to access essential medicines. So let's compare, for example, 2 high-income countries where large disparities exist, such as the US and China. So let's start with the US. the health spending in the US per capita, Dipti, is double the amount spent in any other high-income country in the world, and that includes Switzerland. Tell us some major challenges that the US has been dealing with and some solutions that, well, other countries could mirror.
So excellent question. So I'll tell you that if you look at the last 70 years and look at the amount of progress we've made in cardiovascular medicine in terms of science, it's been phenomenal. We delineated the pathophysiology of myocardial infarction. We've developed VADs. We've developed, transcatheter therapeutics. So we have great science. We also have great technology, right? We're a very tech-savvy profession. As I just mentioned, VADs and transcatheter leadless pacemakers. So we do a great job of care in the hospital. So we do a great job with sick care. But what we don't do as well with is the delivery of our care. If you look at a waiting room 70 years ago, the same 70 years where we've made progress in terms of all of this technology and science, and you look at a waiting room now, it's fundamentally the same. So what we haven't done well is the delivery of our care in terms of, and how we deal with outpatients. And as a result, we have variation in care depending on where you live, depending on geography, depending on what you have access to. So I think that plays a role. That's a huge challenge. It goes to the inequities that are already built into the system in some ways. And I think that the pandemic really brought to the forefront the health equities that have been existing in all of our societies for a long time. And I think we're having to focus on it in a way that we've never done before. So I think that's one of the big reasons. And I think that we're starting to really look at how do we deliver care outside of the hospital? How can we really shift not to true healthcare? We think we're doing healthcare, but what we're really doing is sick care. So how do we do healthcare? How do we get rid of some of that variation of care and deal with health equity? Because I think the road is we want better health and we want improved economies. And we know that if we improve the health, then we're going to improve the economy. And maybe we need to shift the conversation, not about just cutting costs, but to actually make a true investment in health.
That what you just said is so important about the differences between sick care and health care. It's true that we're only focused on the people who are sick, but not really on the people who are healthy and how to maintain them healthy, right? So that's incredibly important. Now, I also want to hear the perspective from all across the world, from China, the other corner of the world. We have the US and then China here from Junbo G. Now, even though China is considered a high-income country, there are still huge disparities at the economical level, political level, and of course, in health. So can you give us, I know it's going to be difficult here, but a succinct and general overview of how the medical system looks now and there, especially, of course, after COVID.
Okay, thank you very much for the question. Actually, I totally fully agree with the idea that Dipti just mentioned. Actually, I witnessed actually in last years, especially last 40 years, the spectrum of a cardiovascular disease. When 40 years ago, my first step out of the college, and we do see less heart attacks. And in the last 40 years, because the people get wealthier, they eat well, over diet, we have more and more people obesity, diabetes, hypertension, and dyslipidemia. And last year, according to the government information, and we have 330 million cardiovascular disease patients. Among these, 270 is hypertension. That is, hypertension is the most important challenge in China, but we have 110 heart attacks, heart failure, so on and so on. And if you see this very carefully, this happens in the last 40 years. And we do have to appreciate or to thank to the Framingham study that in US they did, and this risk factors control. And in US and in Europe, you do see that the heart attacks decreasing
But in China, we do see still increasing. As you mentioned, from the East Coast to the middle and west part of China, the economics are not very, very balanced. Therefore, we do see a lot of people still suffering and these heart attacks. Now, if you ask me the question, what about in China we have to do? I think we have already started. We are now try to not only take care of the sick, but also the healthcare system. We try now to upstream to control the risk factors, hypertension, diabetes, smoking, tobacco control, and also the dyslipidemia control. And still, we do see now in last years also the pollution, air pollution, and also plays important role. We just published in circulation regarding for the heart attacks. Therefore, I think this is a whole project, not only to focus. If you ask me what China will do, we in the last 5 years, the scientists, they raised a new concept. We take patients as a whole. Because if you think the stroke happens, heart attacks, renal disease, peripheral disease because of the high diabetes, so it's one disease, it's a vessel disease. Only it occurs in different organs. If you think this in details, you said, okay, we have to block this vessel disease, and then you have a healthier world.
Okay, so that what you said was very important. Just to summarize what Junbo was saying in here. So you were saying that when you were back in college, everybody seemed super healthy. They all had their heart health very regulated. But now, and in recent days, the heart attacks have increased at an alarming rate. Can you repeat the number of heart attacks that you've had in the last year?
Yeah, we have 330 million.
330 million.
The cardiovascular disease, but also including 270 million hypertension. This hypertension is most
270 million people with hypertension, which is some of the most basic, you know, in the heart disease spectrum, but still not very much controlled. All right. So, is there any specific action? You've talked now about pollution, for example. Is there something that the government is doing to regulate that or to diminish that?
Yeah, from I think 8 years before, that the government pay more attention to the environmental pollution, and now we try to recover the trees, rivers. We have more blue skies, clear waters since 8 years and now. And also, I think most importantly, we are the Chinese Cardiovascular Association since 8 years also. We are now build our chest pain centers, which we have 5,000 chest pain centers, which covers the whole China, every corner. And we are decreased the patient with acute myocardial infarction from now without chest pain center before was roughly 5.something% to 2.6%. That dramatically decreases the mortality of heart myocardial infarction in hospital mortality. I mean, and also we build a hypertension leak center, the center with AF, atrial fibrillation, to prevention of stroke, and we have a prevention of rehabilitation at the valve center. And after the last years, and we have a system, we build a system that really covers the network, the whole China, and we do see also the change. It's in the direction of a better way.
Okay, well, we hope that by 2030 we'll see a significant change. We'll come back to that.
Hopefully.
Right.
Thank you.
Now, Monika, really quickly here, as president of the NCD Alliance, what do you see are the most important enablers in low and middle income countries to address inequity, for instance, in research and data?
So definitely more research is needed, but also realizing that research to program and policy, there is always a delay. So we need to have implementation addressed much earlier as the research is out, not leaving it for the policymakers to look at it and then take action. It is very important to the first point, as you mentioned, that we are able to advocate to policymakers as well as the program planners well in time to be able to accept what is the research outcome. So research to policy action has to be more robust and more quick. Also talking about technology as an enabler. So it is definitely helping us collect data much faster. Electronic decision support systems provided to physicians have shown to provide better management of blood pressure, hypertension, because the prompts are accepted by the physicians, and it reduces the time which is given to the patient. In terms of reduces the time that a physician is spending on too many patients, so they get better care and advice in terms of their physician care. But I would also like to highlight here a very important point, that we do talk about technology as an enabler, but important is that we understand the communities. So in our community conversations in rural areas, when we talk to patients that why don't you access health system, why don't you go for diagnosis? So the answer we got is that if I am diagnosed, my salt and my sugar in my tea will be stopped. I don't want that. So I think any amount of technological development would not be successful till we don't have community mobilization. Meaningful engagement of patients is so very important when we are planning these programs. Unless they don't come to the health system, there is no point that we keep having technological advances.
That is very important. Yes, we tend to have sometimes these conversations only with doctors or experts that are familiar with the health system, and we rarely do we have many patients, especially in this room as well. So that's also something very important to consider. And on that note, also talking about doctors and patients, let's address another big reality. There aren't enough doctors to meet the demand, and it is likely to get worse. By 2050, we'll go from 1 billion people aged over 60 to 2 billion people aged over 60. So that is many more people at risk of non-communicable diseases. And that, of course, will provide more medical personnel, more money out of the system, and a global GDP increase spent on healthcare. So let's talk about some solutions we can approach. You mentioned technology before. Is that maybe some obvious solution here to tackle this, well, this significant problem?
So first would be prevention. We are all focusing so much on treatment and management. So it's like we are continuing to mop the floor without turning off the leaking taps. So we have to focus on prevention so that we have a lower burden on the health system. Also, important technology is definitely a solution where we are able to provide electronic support to the physician, but also to the patient. Let's have patient-facing electronic support as well, apps which they can access for their regular treatment and care instead of flooding the OPDs every now and then for advice and for follow-ups and things like that. So technology is a big enabler when we want to address the shortage of physicians and doctors. Also in the remotest areas where people have to travel very far in low and middle income countries to access even a primary healthcare setting, it is important that we have this support. Again, I would like to bring a caveat here is empowering them to use that electronic support. Literacy is a big barrier. Age related challenges. Many people during COVID who were over 50 could not access the electronic support which was available. The telecounseling wasn't available to them because the phone for them is to speak only, not to be able to enter their credentials and access the health system. So it again comes down to empowering people to be able to use technology.
Dipti, any further challenges from your part to leveraging such technology?
Yeah, I think technology, I think that Monika highlighted some of them, but I think there's clinical adoption, There is, what's the data like, and then also the patient preferences. I think all of those are barriers. So let's talk about just in general. I think when these tools are being developed, digital tools, a lot of it is they're coming up with solutions before we know what the problem is. So what we really need is sustainable, actionable, we're actually tackling issues. So we need solutions for things that we have, that we want to solve. So that's one thing. And then the question is, how is it going to integrate in the workflow? You can't take a paper solution and make it into a digital solution. It needs to be a digital process. So does it fit into the workflow? Is it cost effective? If I am and my healthcare system is going to spend X amount of money, is it cost effective? And then we're going to be incorporating, say, artificial intelligence tool. What is the data analytics that are used to develop these pathways? We need to be aware of all of that so that the clinicians can trust the data, can trust the information that we get. So we need proof. I think that at least in the cardiology community, we're very good at adopting technology as long as there's proof that it works. But if you look at the data, a lot of it is, to be whatever. It doesn't get incorporated in the guidelines. Why? Because we haven't had credible data. So we need credible data. We need trust in it. So for the clinician to adopt it, you need the trust factor. You need to make sure that, as I mentioned, the cost effectiveness, the workflow issue. And then I think in terms of the patient, we need to make sure that there's broadband access. We need to make sure there's digital literacy. We want to make sure we don't create the digital divide with all of these tools, because then we're actually making the issues worse than we were before. So I think this is where we need to shift our thinking. Most of what we do in medicine is downstream. We need to go to upstream thinking and say, what can we do at the onset of this so that we can prevent those downstream problems?
Now, Junbo, anything you would like to add on this? Health and artificial intelligence innovations are emerging at such a fast speed after COVID-19.
Sure. Actually, since 5-6 years, we start we call digital twin system. Most of us will have read a novel that the Snow Crash, which was published 30 years ago, and now we frequently mention a term megaverse or metaverse, megaverse. But I think it's important now we try the hospital like this or the medical system worldwide, no matter in US, in China, or everywhere. We are waiting for the patient to come. We care of the sick. We never take care of the patient who are not yet sick. It's ill already, but not yet sick. Therefore, I think we are now starting, since years, the system. They develop a AI system called Junior. My name is GE. In Germany, they call me G also, but they call Junior. I'm a senior, and we try to develop such a system which copy any digital twin of anyone who is not ill, and you deliver your every message to this system. And me myself, for example, as a human being, but in the mega system should be someone like me, everything. But first, we now try to protect our privacy. And secondly, we should have all data in the system. And in the future, maybe 10 years after, they can give to foresee what the incidence, what the probability of heart attack, and how many coffees I drink today, or the smoking, and what things happens. It is stored in a system. We try to build such system, and this is now we only using in China for the management of chronic disease, heart failure, so and so on. We just mentioned the patient, you have to now come to the hospital to get checked. But I think in the future, as the development of AI, I think we could have such a system we call digital twin to help us to help people, for everyone. This first. Secondly, I think it's extremely important not only rely on the hospital. We have to every citizen, every human being, they are responsible for their own health. Just like the mission, we have cardiovascular health, not cardiovascular disease, cardiovascular health for everyone. Therefore, I think the patient themselves or the human being themselves, they have to really upload their own information, and therefore we have a better world, and we can really to have our cardiovascular health for everyone.
Now, Ivor, I want to talk about how we can bring how we can maximize new technology by taking it up to the political level, by taking it up to the political agenda. Because at the end of the day, if we want more technology to tackle cardiovascular disease or to maintain cardiovascular health, as we were speaking before, we need the money. We need the budget. So how can we put it in a priority in the political agendas?
So, Arianne, in our briefing, you told me that you really wanted this to be a real conversation. So if you're ready.
I'm ready, bring it on.
There goes. So we have not, I think, began to talk of what we call the social determinants of health. Let me sort of break it down. If you were to use, when we talk about social determinants, we're talking about where people live, where they work, your zip code. But before I go to the zip code, let me tell you about my geocode. My geocode, I was born in a country that will be considered low to middle income. I was fortunate to be able to get some of the best education in the world and be a physician scientist, and I realized my life dreams. But when we talk about the social determinants of health, it's really about engaging our politicians about those social factors. If you don't have access to broadband, you can have all the technology in the world, it really doesn't matter. And so those are issues that are across the world. These are issues for which we know and understand. And so if I want to control hypertension, diabetes, but really being able to engage people around those things that will promote health really is about really breaking down the social determinants. And I think that those are ways in which we can actually communicate with our politicians in a way that is understandable for them. So if we become partners, we can actually bring more people in. We can bring in the technologies companies to be able to reduce the costs. Even as much as we are high income in the United States of America, there are huge health disparities depending on your zip code. Right?
It is so true. So, yes.
So, and I was going to say that, there's a lot of groundwork that we need. So besides broadband, we need data harmonization. If we're going to use technology, we're going to have to exchange the information. And what are some of the regulations around the data harmonization, exchange of data? We need all of that, and we need to have the political system be part of that regulatory environment that we need to create before we can actually use technology effectively.
Yes. So you were saying that we have to take it at a social level, and we need to integrate conversations with our politicians more. And you said also that it all comes down to broadband, that you can have all the technology in the world, but if you don't have broadband, I mean, how can people connect if they don't have internet, if they don't?
But they also have to have literacy. I mean, they need digital literacy. There were people that did not want to use their smartphones or want to do a video visit because they weren't comfortable doing that. They'd much prefer the telephone visit, for example. So again, if we want them to use technology, we need to make sure we teach them how to utilize that technology.
Okay, so what do you propose?
Let me take a stab. Those of us who have the means, we get up in the morning and we go to a health club. But let's be sure that people can walk, be it night, be it the day, whenever the case may be. They have to have safe places to walk, right? You wouldn't go outside if you don't, so I think that access to really parks, playgrounds, but more importantly, begin to incorporate those healthy lifestyles early on, so that we can tackle the issues around obesity and many of the other sequelae, that contribute to adverse outcomes for both heart disease and stroke. And again, these are policy issues. These are issues where if you really break it down and make people, this is a wise investment. A healthier society in terms of people. Yes, one of the things that we haven't discussed is the number of people who are actually working virtually. Well, if you're going to work virtually, the time that you used to have to basically get that 1 mile in, walk into the subway or walk into the train station or to the bus, that's no longer happening. Are you taking time out? So part of the health literacy is to say, yes, the convenience of virtual work should be complemented by going outside, getting fresh air, and this ties back into what you were talking about climate change, you know, the environment and everything else.
So talking about climate change,
Yes.
how can we bring the health, the cardiovascular health at the top of the climate agendas? Is it integrating and uniting, for example, congresses that have to do with climate change, with congresses that have to do with heart health or health in general? Is that one solution, for example? How can we better integrate both?
I'm sure my colleagues are going to give you some more eloquent answers, but you know, we understand the science around, if you will, the ozone and many oxidants that can potentially affect heart cells and begin to remodel how our vessels behave, be it in the brain and the heart, but I'm sure, you know, you can get some more eloquent comments.
Monika or Dipti, I see Dipti.
Well, I think I just wanted to go back to the social determinants of health. I mean, I think the most, when you talk to clinician audiences, I think the thing that's the aha moment is to say only 20% of a patient's health and well-being has to do with what we do in terms of the healthcare we provide. 80% has to do with all of those social determinants of health. And this is where the conversation with the broader, you know, community of legislators and our health ministers, all of that helps, because I think they need to understand. So what is it that we need to do to interact? And as a clinician, you may feel like, well, I don't know how to overcome some of those issues. I know what I can do with an individual patient, but we need the collective community to be part of the solution. I mean, I was reflecting on the fact of what you said, if people are working at home. I just saw some data that said that they were showing obesity in women and how that had increased when women started to go work and not do housework as much, because they were hiring people to come and clean homes and stuff. And all the activities that you did at home and how much an energy expenditure that was in high income countries, and certainly not in low and middle income, but I'm just saying lifestyle changes that are for the better sometimes have adverse consequences, and we need to be aware of those and mitigate those.
I would like to add, apart from social determinants, we need to address commercial determinants of health, which are so very important in contributing to cardiovascular diseases. So cardiovascular diseases, again, is complex. The solutions are not with the health ministry itself, they are multi-sectoral. So we need to advocate not just with the health ministry, it's Ministry of Finance. We know what are the population level interventions which are cost effective and would provide population level protection. So tobacco taxation, alcohol taxation, advertising bans, the best practices are available. We need to adopt a multi-sectoral, whole of government, whole of community approach to be able to address cardiovascular diseases and change it from what was being said, not cardiovascular diseases, but cardiovascular health.
Monika, and to finish off, there are still some challenges in some of the basic aspects. Junbo here was just telling us how the numbers of hypertension in China, so big, it's the majority, I think, of the condition that we have in the spectrum of heart diseases in China. So just a little bit of statistics in here. Hypertension is very easy to control, very easy to diagnose, and very easy to treat. Yet, worldwide, only 50% of people with hypertension know they have hypertension. And in that segment, only 20% control it. So how can we tackle bigger issues in the cardiovascular world if we're not even able to control the most basic condition?
I think this boils down to fragmentation of our health system. A physician would attend to the patient only for the complaint he has come for. They would not check him for diabetes, which is a quick test. They would not test the blood pressure. And this is where we need to have integrated responsive health systems. A patient with cardiovascular disease would have some multimorbidity. They would have diabetes, for example. So a patient has to go to a cardiologist as a specialist, then he has to go to an endocrinologist, and then to another for mental health. So I think this fragmentation is one of the barriers. People are not able to access health system effectively. So if we are able to work out integrated, responsive, and resilient health systems, much of these barriers can be overcome.
Well, the barbershop study showed that care where you are can sometimes help, right? So I think hypertension care, they did a better job when they were able to go to the local barbershops and treated the hypertension. I think that the idea with things like hypertension as some of the risk factors is there is data that shows that individual level interventions are not as successful as system level interventions. And I think that's something we need to incorporate. And I think that's where we were talking about technology and all that. But I think we definitely need to have more local solutions for some of this.
Yes.
And last but not least, I think we have really to strengthen that cardiovascular disease is not only an issue of medical systems, it's an issue of the whole human being. And we have to get the patient, the family members involved. Now we know exactly now everywhere they're developing the wearable devices, the smartwatch, and to watch the blood pressure, glucose, and things, the parameters, and so on. I think in the future, we get the family members of the whole society get also involved to the health, not only when they become sick to the hospital, rely on the hospital only. I think in the future, because of the development of the new devices and the smartphones, smart watches, and so on, we can monitor all the parameters. As I mentioned, we have everyone. I do believe in the very near future, we have the digital twin, or we call cardiovascular, something there, and we can really take care of the health for each one, for everyone.
Good. Now, because we're running out of time, I wanted to have a last question for you to sum up the discussion. So in less than 15 seconds, I want you to give me one viable solution to realistically implement by 2030 with a positive impact, and why? But in 15 seconds, let's see how they're able to do this. Okay, I'll start with you, Ivor.
Happy to go first. Look, when someone presents with a heart attack, that was an incubation period of 30 years. So if there is one and most important thing is to understand risk factors for cardiovascular disease and have that be practiced every day.
All right. Now, one viable solution specific, what would you do if you had all the power in the world?
To eliminate the cardiovascular disease, I think we should take the patient as a whole. As I mentioned, the panvascular. We take care of the whole vessel, not only heart, not only cerebrovascular, not only peripheral vessel. Take the patient as a whole.
As a whole, all right.
I think I would tackle it from the existing environment, and I would say that if we could do one thing, it would be to truly embrace digital transformation, really make that transformation. And let me just define it. I think digital transformation is not a technological thing, but it's a mindset. I think it's a way that we embrace data and utilize that data to improve health. So I think if we can really embrace digital transformation, then we're going to really make headway towards health.
Monika?
I would say that we integrate it with other ongoing campaigns like universal health coverage. So we are able to get a larger area covered in terms of having support for getting treatment, and finally, most importantly, increased investments in NCDs and cardiovascular health.
Okay, so digital health and increased investment in, what was, remind me the last one?
Integrating with universal health
Integrated
coverage.
With universal health coverage. Well, thank you so much for your insights in here, but above all, thank you all for listening. Let our global vision here be to create healthy environments for cardiovascular health, continue advocating for support at political levels, equitably deploy tech that can reach underserved communities, and integrate all levels of care. To achieve these ambitious goals, we do need to act together, but we do need to act now. Thank you.